Thank you so much for having me today to talk about curative therapies for sickle cell disease. I am Dr. Julie Cantor. I'm the director of the Adult Sickle Cell Program at the University of Alabama, Birmingham, and I also co-direct our Lifespan Sickle Cell Research Center. Again, thank you so much for honoring me with having me here today. These are my disclosures, but are not relevant to the discussion today. So I'm hoping that we will allow for the audience to have a better understanding of the ways and approaches to curing sickle cell disease, recognizing the barriers of traditional stem cell transplant in sickle cell, better understand the different types of gene therapy for sickle cell disease. I'm going to briefly talk about understanding how you measure efficacy and success in sickle cell gene therapy, talk about some of the risks and benefits of gene therapy, and then have a discussion about the understanding of what a cure in sickle cell should look like. So let's start off with the basic biology. This is a picture of hemoglobin. It shows the 4 chains, and it shows the heme and the iron in each one. It's a multi-subunit protein with 2 alpha and 2 beta subunits. And that heme in the middle is what carries the iron and has the oxygen. The pathology of hemoglobin is that it can be qualitative, meaning the hemoglobin is broken or misshapen, as happens in sickle cell, or it can be quantitative in thalassemia, where you're missing some or part of those chains. When we think about sickle cell disease, it's important to remember that it's a monogenic disorder, meaning there's one single point mutation that causes the problem that causes the actual sickle hemoglobin. This was actually the first monogenic disorder identified. So even though it's just one simple point mutation, it takes this normal hemoglobin here and transforms it into the sickle hemoglobin. That's because the abnormal hemoglobin then polymerizes upon deoxygenation. That means that when there's not enough oxygen and the oxygen is released from the red cell, it causes all the sickle hemoglobins to stick together. And of course, that results in severe anemia, pain, end organ damage, and shortened lifespan. However, it's actually not just about the red blood cell. In fact, we see complications that arise even before that red blood cell sickles due to the loss or release of free hemoglobin. That free heme is very toxic to the inside of the blood vessel. It soaks up nitric oxide and it causes damage and inflammation to the inside of the blood vessel called the endothelium. As a result, we know that when the cell does sickle, it allows for platelets, neutrophils, and sickled cells to stick more to that endothelium. So it's not just sickled cells sticking to the inside of the blood vessel, but the inflammation allows more platelets and white blood cells to stick to the inside of that blood vessel as well. As a result, there are multiple complications in sickle cell disease. In fact, there is no part of the body that is not affected by sickle cell disease. So when we think about looking at curative therapies, we want to think about all of the different parts of the body that could be affected by sickle cell. So can we actually cure sickle cell disease? Well, we first described it over 100 years ago in a student that came from the West Indies. It's amazing that it's taken so long to get to where we are now. And the current therapies are very supportive, but not curative. That includes transfusions, pain management, hydroxyurea and L-glutamine, and the more recently approved therapies in the United States, voxelotor and crizanlizumab. So the fact that we have mostly palliative therapies or supportive therapies still is a huge health disparity that we do not have more options to treat individuals with sickle cell disease. This is actually Dr. Herrick, who originally identified sickle cell disease in 1910. When we think about stem cell transplant, it is important to understand where stem cells come from. They're in the bone marrow. These are hematopoietic stem cells. That means that these stem cells cannot produce things like a new foot or a new hand. They can only produce blood cells. This is important because that is all we're trying to achieve, is to improve these stem cells so that the blood cells they produce do not contain sickle hemoglobin. Hematopoietic stem cells form lymphoid cells and myeloid cells. And it's these myeloid cells that eventually go on to produce red blood cells. So let's talk about stem cell transplant. There are three main types of traditional stem cell donors. There's a matched related donor, which is a brother or sister who has the same bone marrow type as the patient, and they have the same mother and father. There's a matched unrelated. This is a volunteer who happens to have the same HLA or bone marrow type as the patient, but is not related to them. And then there's a half-matched or haploidentical. This is a half-matched family member, usually a mother or father, but could be a brother or sister. And this type of donation is still experimental, and we only recommend haploidentical transplants as part of a research study. We do bone marrow matching by a special blood test called HLA typing. So your bone marrow can match even if your blood types do not. So we need to talk about the complications or risks associated with stem cell transplant. The first is that its chemotherapy is still required for most types of transplant. So it is important that we understand the side effects and complications of chemotherapy. There's hematologic toxicity or risk of bleeding. There's a risk of increased infection from low white counts, mucositis or ulcers in the inside of the mouth that can go all the way through the GI system caused by the chemo. There's also a risk of graft failure. This means the transplant or the new cells don't take, and that is of course a huge risk because the individual would likely continue to have sickle cell disease. There's a primary rejection where they never take, and a secondary rejection that can occur later on after it seems that the transplant has been successful. There's also graft versus host disease. This is when the new bone marrow from the donor starts attacking the patient. It can be acute in the first few weeks of transplant or chronic and something that can happen long time. And it's higher with individuals who receive a transplant from a matched unrelated donor. And there's other organ-specific complications. The main one here is fertility. We know that most chemotherapy will cause individuals to become infertile. There's neurologic complications that are especially high risk in individuals with sickle cell. And there's possible liver complications as well. Finally, some of the chemotherapy can cause cardiac or pulmonary complications. So why is sickle cell ideal for a stem cell-based approach? Well, as I showed you, it's caused by a single base pair mutation in the beta hemoglobin chain. This results in the actual sickle hemoglobin being produced, which causes the sickling itself. And the shortened lifespan of those red cells, the often release of free heme that's toxic and inflammatory to the inside of the blood vessel. So the stem cells can serve as a vehicle for a therapeutic gene delivery, whether that's a stem cell from someone else, as in the case of stem cell transplant, or in the case of gene therapy. And we believe that many complications can be halted or completely resolved if the damaged red cells are replaced with red blood cells that make healthy hemoglobin. There are multiple current indications for stem cell transplant. Right now, it is usually reserved for individuals who've had severe complications of their sickle cell disease. For children here on the left of the slide, that's often children who've had a stroke or an abnormal transcranial Doppler that tells us that there is a high risk of stroke. There's also individuals who've had recurrent pain crises or acute chest syndrome. On the adult side, it's often individuals who've had a stroke or have acute chest that continues to happen despite best supportive therapy. Those individuals who have recurrent vaso-occlusion or possible side effects from sickle cell disease that show heart problems, an elevated tricuspid regurgent velocity, or kidney problems, which is sickle nephropathy. Allogeneic transplant, stem cell transplant, is curative in sickle cell disease. The first paper that had a large cohort of individuals was in 1996, and they discussed 22 children who'd undergone transplant. They had myeloablative conditioning with a large amount of chemotherapy, and their overall survival was incredible at 91%. But they still saw a lot of rejection of 18%, meaning that some of those grafts didn't hold and individuals went back to having sickle cell disease. However, it was proven as curative from this point forward. The group in France, led by Dr. Bernardin, has gone on to really demonstrate the amazing utility of stem cell transplant. In this study, she showed how 87 consecutive patients had severe sickle cell disease and had severity mostly because of cerebral vasculopathy. In other words, had had a stroke or had abnormal blood vessels of the brain due to sickle cell disease that increased the risk of stroke. This also used a high myeloablative conditioning regimen, and all of the children received a sibling-matched transplant. After they introduced another chemotherapy or immune therapy called ATG, the rejection went very low to 3%, so most people no longer rejected their marrow. But they still had individuals who had graft versus host disease, and we certainly don't want to trade sickle cell for graft versus host, a new chronic problem. Importantly, there were no new ischemic or stroke lesions after these individuals had engrafted. So in other words, it was curative for the brain. And the outcome improved over time as we've gotten better at managing these individuals, such that the event-free survival rate among the 44 patients who were transplanted after the year 2000 was 95%. That was very high. So there was also a more recent article from data in the CIBMTR, which is a registry of individuals who undergo stem cell transplant. Here they looked at 1,000 patients who'd undergone a matched related transplant between 1986 and 2013 and saw a 5-year overall survival of 92.9% and an event-free survival of 91.4%. It is important to note that these numbers were even better if children were transplanted before 16 years of age. They did still see a lot of graft versus host disease, however, with about 14% acute and 14% chronic. So we started to ask questions about, do you still need full-blown chemotherapy or high-dose chemotherapy called myeloablation? And what they noted in this study here by Walters et al. Was that in individuals who are cured of their sickle cell disease, it was okay if some of their own bone marrow came back. We call that mixed chimerism. That's when some patients have part of the new bone marrow and part of the old bone marrow. And that in fact, they didn't need to be 100% donor to still be cured of their sickle cell disease. So this suggested perhaps we could use what we call a non-myeloablative regimen, give less chemotherapy, and perhaps preserve important aspects like fertility. This was one such regimen where we used an immune modulator called alemtuzumab that affects the immune system but doesn't affect the whole body as chemotherapy does. These individuals do get radiation, which still does cause a risk of having fertility problems. And then they get a newer drug called sirolimus to help prevent graft rejection and graft versus host disease. This transplant regimen was used in adults, because remember I told you most of the original transplants were performed in children. And in this initial group of 10 adults, they found that they were able to cure 90% or 9 of those 10 with sickle cell disease using this regimen. We look here at a more recent paper that showed us 55 patients who were transplanted. This is 54 with sickle cell disease and 1 who had thalassemia. We can tell that the transplant regimen continues to be highly successful, and you can see that 47 patients had initial donor red cell engraftment, so highly successful with no graft versus host disease, and these were older patients. Unfortunately, we still had 7 individuals who had graft failure, meaning they did not accept their new graft. The overall survival was 93%. There was no transplant-related mortality or death, and the event-free survival was 87%. Interestingly, 8 of these individuals who've been cured from their sickle cell disease had healthy babies after transplant, suggesting that this regimen does in fact possibly preserve fertility. These results have since been duplicated at other institutions. These were originally done at the NIH, but more recently have been done at the University of Chicago, where again they saw 92% event-free survival with no graft versus host disease. A group in Saudi Arabia also performed a similar transplant and saw no graft versus host disease. And then in Alberta, Canada, they had children using this regimen, where they also saw 100% event-free survival, meaning 100% of those children were free of sickle cell disease and cured, and did not have graft versus host disease. Again, telling us that it is very possible to use non-myeloablative chemotherapy and have no graft rejection or graft versus host disease. So now we're looking at using this more broadly in children. This is a study called the SUN study, sickle transplant using a non-myeloablative approach. And we're hoping to get more information. Since 2018, they've had 17 patients enrolled 13 transplanted, and 11 had had at least 1 month of follow-up when this slide was made, courtesy of Dr. Fitzhugh at the NIH. And again, we saw that these individuals were doing very well. 10 of 11 are alive and free of their sickle cell disease, and there was no graft versus host disease. Now, it does take a while for individuals to remain on sirolimus, and 3 of 4 were weaning off at 1 year. So this begs the question, if our results are so awesome, why aren't more people with sickle cell disease receiving stem cell transplant? Well, the vast majority of individuals with sickle cell disease don't have a matched sibling. So they've looked at using matched unrelated donor transplant. And this is in children with sickle cell disease in a study called the SCIRT study. And here, 29 patients, average age of 14, were transplanted. The 1-year survival was 86%, and the overall survival was 76%. That tells us that 6 children died from graft versus host disease. This is much higher than the studies I showed you previously, showing us that perhaps matched unrelated donor transplant is not as acceptable. When we looked at adults with matched unrelated donor transplant in a study called the STRIDE study that enrolled 22 patients, we see that 5 of these patients, so 5 of the 22, were matched unrelated donors. The others were matched related donors. In this group of 5 patients, only 3 were cured of sickle cell disease, although 1 was later transplanted again and was cured. 1 patient, however, had severe grade 3 acute graft versus host disease, and 1 had chronic graft versus host disease. So again, while these results are encouraging, we're seeing that matched unrelated donor transplants aren't doing as well as we would like. So of course, the other problem is many individuals don't have access to a transplant center, and many adults don't even have access to a hematologist to get advice on optimal therapies. It's important to note that a recent analysis from Florida on almost 1,200 adults found that only 30% had a primary care doctor, only 18% had an adult hematologist. That meant that only 27% had a primary care doctor and a hematologist, and almost 25% had no doctor, a primary care or a hematologist. And of course, as you might imagine, individuals who had both a primary care doctor and a sickle cell hematologist had less hospitalizations and better outcomes. If we can't get individuals with sickle cell to a hematologist, it will be very hard to get them to a transplant. Finally, we looked at haploidentical transplant. These are half-matched transplants, and this was a group out of Hopkins that did a lot of this initial work. These are very accessible donors. It's usually a mother or father. We can get larger cell doses, and you can get repeat cell collections when needed. In this case, they added in a chemotherapy called cyclophosphamide to help decrease graft rejection and reduce graft versus host disease given to the patient after they received the transplant. So we have shown now that stable mixed chimerism is sufficient. We've come up with a regimen that we can use for half-matched transplants. And the initial studies showed us a curative potential in 50 to 75%. There was a high number of rejections, but it was encouraging because there wasn't a lot of graft versus host disease or unnecessary patient mortality. So this has since been modified and improved since then. Additional upfront conditioning with radiation and this post-transplant cyclophosphamide have significantly improved these outcomes. So in 8 patients, ages 20 to 38, transplanted in Chicago, they had an excellent follow-up with 7 alive and 6 free of sickle cell disease. Unfortunately, though, there was still more graft versus host disease with the half-matched transplants or haploidentical than we saw with the matched related donor. When we look at a whole different group of haplo studies that have now implemented this post-transplant Cytoxan, you can see increasing event-free survival over time with very low rates of severe graft versus host disease and mortality. So overall, we're seeing 89% of individuals who have undergone haploidentical transplant down here at the bottom are finding that they are now alive and without sickle cell disease. We are still seeing that 21% have graft versus host disease, and some have extensive graft versus host disease. However, these results are still very encouraging. So should everyone then undergo a stem cell transplant? Well, the short answer is no. Some individuals don't want to undergo stem cell transplant. They don't want to take the risk. We know that it's curable with allogeneic transplant, but it's hard to find well-matched donors. There still is this risk of graft versus host disease. That requires people to be on a long-term immune suppressive medication, such as sirolimus, and that means they have to be close in proximity to a transplant center, which many of our patients are not. There are risks of complications and side effects, such as infertility and infection and early death. So some individuals don't want to undergo stem cell transplant. So we need to look for other curative options. Sickle cell is an ideal choice for gene therapy. As we mentioned, it's caused by a mutation in a single gene. So if we can deliver a functional gene, we hope this could reduce the symptoms of the disease. We know exactly what causes sickle cell disease, and finally it seems we have the tools to contemplate a potential one-time cure. So what does gene therapy mean? Well, gene therapy is designed to introduce genetic material into cells to compensate for abnormal genes or to make a beneficial protein. In this case, we're using stem cells to deliver a normal hemoglobin gene. Gene therapy is an experimental technique that could use genes to prevent or treat disease. In the future, we believe this technique can allow doctors to treat a disorder by inserting a gene into cells or altering a gene that's already there instead of drugs or surgery. How does this work? Well, we take individuals with sickle cell disease and we take their stem cells, not all of them, of course. We do this through a process called pheresis. By then, we add a correctly spelled beta globin gene, that missing beta globin that's misspelled. Or we can alter other cells to make healthy hemoglobin. Patients then serve as their own donor. This could be more readily available, and individuals don't need immune suppression afterwards. There's also no risk of graft versus host disease. So there are a couple of different types of gene therapy. One is called gene addition therapy. This is where we add in that new gene that makes healthy hemoglobin, but we don't remove or change any of the individual's existing genes. So that person will produce their sickle hemoglobin, but they'll also produce healthy hemoglobin, just like somebody with sickle cell trait. We usually use a viral vector to do this, a viral envelope, and we add this corrected gene inside. This viral vector allows it to enter the stem cell, and the corrected gene goes and fits itself into the person's DNA. There's also gene editing. This is where we don't add a new gene necessarily, but we edit a gene that is already in the body. There's a couple of different ways of doing this. Zinc finger nucleases is one way of doing this, where they're artificial proteins that bind and cleave very specific DNA sequences in the genome. Another way of doing this is called CRISPR-Cas9. This has two components. The CRISPR is a strand of guide RNA that can identify a very specific string within the DNA, and it's attached to a Cas9 nuclease. Think of it like a chemical scissors. When we look at CRISPR-Cas9, I want you to look here in this upper box on the left. You can see this is that CRISPR strand that I told you about that only matches to a very specific DNA sequence. And it's bound to this Cas9, which are the chemical scissors. When it finds a match, it binds to a very specific location over here on the right. Only that one location will match this CRISPR guide. And then down here on the left, that Cas9 will cut both strands. The body then fills in the middle with new genetic material. So in this case, we use it to turn on a gene that makes fetal hemoglobin or baby hemoglobin, so that individuals will make both baby hemoglobin and sickle hemoglobin, again, very similar to individuals with sickle cell trait. However, there's another way of doing this too, where we not only cut the DNA, but actually add in a new piece of DNA at the same time. This is called HDR, or homologous directed repair. Very similar to what we just talked about, we use that CRISPR-Cas9 up here, as we mentioned, in that box A, to bind to a very specific site and create that double-stranded break. But then on the right, when they deliver that CRISPR-Cas9, they also deliver this green SNP that is a perfectly suited piece of DNA to fill in that hole that they've made. This would allow us to directly cut out that sickle mutation and put in a DNA code that codes for healthy beta hemoglobin. There's also newer genome editing approaches that use part of this CRISPR mechanism, but they do direct point mutations. So instead of making that full double-stranded break, these base editors have a catalytically disabled nuclease fused. So in other words, they have a different type of enzyme that only cuts one specific base pair. And that can allow us to convert one base pair to another, as you can see here. This is called base pair editing. So where does the HIV come in? A lot of people have asked about that. Well, some of these gene therapies use lentiviral vectors for a gene delivery. What does that mean? I want you to think of a virus as having two parts, an envelope and a letter. And what we've been able to do in the laboratory is remove the letter that codes for HIV. You take it out. From there, you're left with an empty envelope that you can put the hemoglobin gene in. So now you have your viral envelope, but you don't have the instructions that actually cause HIV. From there, you package that hemoglobin gene in the envelope, and actually, scientists use pieces of other viruses, such as VZV, to help make sure that envelope only gets delivered specifically into the blood stem cells and nowhere else. So then what language do we use when we talk about gene therapy? We use vector copy number. That means how many of those gene therapy letters that I just showed you are successfully delivered to a sample of blood cells. We also ask about transduction efficacy, which is the percentage of blood stem cells that have actually received that letter, and the cell dose. How many of the patient's own blood stem cell doses do they get back? This is an example of how we interpret those data. Here on the left, you see stem cells, and each stem cell received one copy of each letter. That means they have a vector copy number of 1, because it's one letter, on average is 4 letters per 4 stem cells. And since each stem cell received the letter, the transduction is 100%. In the example in the middle, 2 of these stem cells didn't get any letters, but 2 stem cells got 2 copies. So you still have an overall copy number that's 4 divided by 4 cells, So your vector copy number is the same, but your transduction efficacy is only 50%. In the case that we don't want to see over here on the right, we see 3 stem cells that didn't get any letters at all. Only 1 stem cell got 1 copy. So now you have 1 copy per 4 cells. That gives us a vector copy number of 0.25 and a low transduction efficiency. That means that this individual won't make a lot of this new hemoglobin. So what are the risks? Well, gene therapy does allow random vector insertion sites. In other words, that new gene can insert itself into various locations. However, we can monitor this very closely. What we don't want to see is what we call clonal dominance, which is when one insertion site is a lot more than all the others, because it could cause a cancer. These individuals still have to get chemotherapy, and we've discussed those risks. And there's still a very distant risk that that viral envelope could have some part of the virus in it. And so we do monitor, which thankfully we have not seen. Gene editing, like gene therapy, can also have unintended modifications or off-target effects. The technology allows us to modify for these, but it's theoretically possible that some smaller mutations could occur that we can't see and can't test for. These still use chemotherapy in order to make space in the bone marrow, and they sometimes use viral vectors. They also may use a technique called electroporation, where they shock the stem cells in order to get that CRISPR-Cas9 on the inside, and that could lead to decreased stem cell survival. But the biggest risk, I think, is the failure to get clinical improvement. What we want to see most is improvement for the individual patient. So how do we grade a cure? Well, first we have a biologic definition. How much of the new gene or altered gene is being produced? And does that stop the cells from breaking down? And does that stop the sickling? And does it stop the cells from sticking to the inside of the blood vessel? Pain, one of the biggest problems in sickle cell disease. So we want to see a complete reduction of pain episodes or a near complete resolution. We also want to see fatigue improve and other patient-reported outcomes. Finally, we need organ-based definitions of a cure. We hope that this will stabilize any organs that have had dysfunction. But if it doesn't, and we see a little bit of worsening organ function, how much is acceptable if we see a biologic and a pain cure? And what do we think the future is? We have to define this grade of cure. We have to make sure we're honest with patients about options and outcomes. We need to monitor long-term, and we need to monitor long-term disease management and cure. And then, most importantly, we have to make this therapy available, affordable, and universal. So thank you again for having me today. We talked about the pathobiology of sickle cell disease, stem cell transplant for sickle cell disease. We talked about why we want to use gene therapy for sickle cell disease, what types of gene therapy we are using, what those risks are, and what the future is. Thank you so much again. Have a good day.